All right, Bismillah ar-Rahman ar-Rahim. I would like to welcome all the participants and the speaker on behalf of Saudi Society of Blood and Marrow Transplant in the weekly webinar series. And tonight's webinar is going to be about how I treat chronic lymphocytic leukemia frontline management. Our guest speaker is Dr. Paolo Gaia from Italy. He is a full professor of medical oncology and he's the director of strategic research program on CLL. He's also the deputy chairman, experimental oncology division, head of B-cell neoplasia unit at the University of Vita Salute San Raffaele, Milano, Italy. Dr. Gaia, the floor is yours. Go ahead, you can share your slides and start the presentation.
Thank you very much, and thank you very much for the invitation. And indeed, tonight, we will be talking about frontline treatment in CLL, and starting from the fact that we all know that we are in the middle of a COVID-19 crisis, but I heard and I spoke earlier with your colleagues here in Riyadh, and apparently the situation for you is much better than what we are experiencing here in Europe and anyhow in the Western countries. So that's the reason why since at least 1 year, we started providing advices to hematologists how to behave during the COVID-19 crisis, in particular for the patient with the chronic lymphocytic leukemia. And of course, there are practical considerations that apply to all different diseases in general, not only hematological diseases. But the major key questions are indeed if there is any immediate risk, additional risk for our patients with CLL if they are diagnosed with COVID-19. And in particular, we have always to balance between the benefit and the risk that anti-leukemic treatment will indeed bring to our patients. So we have always to consider if that particular anti-leukemic treatment is needed in particular in this period, because of course all treatment will likely expose the patient to an increased immunosuppression and therefore an increased risk of infections. And therefore also all the different consideration about which therapy to use, particularly those who will lead to less hospital visits, less interaction with the hospital infrastructure. And so this is somehow summarized in this ASH recommendation that have been also acknowledged and supported by EHA, by the European Hematology Association, where indeed we bring we give some advices, and originally we gave the advices even without any solid data because there was no data at that time. But in particular, we consider the fact that many patients can normally already postpone their treatment because indeed with CLL you have always some time in which patients don't need an immediate urgent treatment. So in particular during the pandemic, the idea of postponing treatment initiation has been really suggested, waiting really for the waves to disappear, because you didn't experience, I heard that you are still probably in the first wave of the infection. We are now entering the third wave. So really it goes and comes back with after a few months. So what we try to develop and suggest is really to increase, to do whatever was possible outside the hospital. So we increase the telemedicine, we increase the delivery of the drugs at home, we increase the blood drawing at home, so they're really keeping the patient far from the hospital. In terms of treatment, we already suggested to postpone the treatment initiation, but for those who were already under treatment, we suggested to continue the treatment because of course the leukemia remains an issue. You don't want to lose control of the leukemia. You have to do it in the safest way possible for the patient. But if the patient is not infected, there is no reason to stop any ongoing treatment, with probably the only notable exception of the anti-CD20 antibody, because that we know are really decreasing for many months. B cells are affecting B cells, and therefore it could really impair the immune reaction and the creation of antibodies against SARS-CoV-2. If patient gets infected, then again, if they have only mild symptoms, if they don't need hospitalization, if they don't need oxygen therapy, then again, we suggest to keep the patient at home. If they are under the anti-leukemic treatment, to continue the treatment without modifying the therapy. That will be stopped only when the patient comes, enter the hospital and needs, goes into respiratory insufficiency, so they need oxygen. So that's really the border that when the patient should discontinue any treatment. So we did in Italy a survey among the doctors following patients with CLL, and the campus CLL is an Italian initiative, and it came out that the doctors actually followed this recommendation, or at least they thought about the same strategy even without our recommendation, which is indeed the patient who were requiring treatment but not yet started with the treatment. As you can see on the left, when there was the first wave, April 2020, the vast majority of patients, 80% of patients, postponed the treatment. While instead, at the end of the first wave, so during summer last year, patients restarted again the treatment as expected, because indeed the situation was completely different. For patients who were on active CLL treatment during the crisis, most of the patients did not stop the treatment. Some, those where the treatment has been modified, were mainly those where rituximab was not given. So really, somehow the practice, the real practice, followed exactly what we recommended. In June, again, at the end of the first wave, all patients went back to their normal treatment, including as well anti-CD20 antibody. The ERIC, the European Research Initiative on CLL, did also a study, a retrospective study. So we collected really during those months patients who with CLL and who also experienced COVID-19, almost 200 patients from all over the world, in particular from Europe, in particular from Italy and Spain, who were the countries who had most infections. And as you can see here, patient, what we saw is that the number of patients, the vast majority who were collected, had a severe COVID-19. Some of them did not have, had only mild COVID-19. And what we found is that there was a correlation between age and severe COVID-19. So those who were older than 65 years of age tend to have were more prone to have a severe COVID-19. The interesting point is that we showed also that the severe COVID-19 was more frequent among untreated patients rather than treated patients under treatment. So suggesting somehow that the treatment and the anti-leukemic treatment were somehow preventing the inflammatory reaction that is well known, that brings the leads to severity in the COVID-19. In that sense, again, this was confirmed from the fact that the patient have been treated recently or not treated recently, and in particular those who were under ibrutinib, they were less likely to have a severe COVID-19. So this went along the idea and the hypothesis at that time that BTK inhibitors could really prevent the development of severe COVID-19, not prevent the infection of the virus, but prevent the evolution into severe COVID-19. A number of studies, randomized studies, have started with different BTK inhibitors all around the world. We are still waiting for the results. That something has been published, not randomized. There are contrasting results. At the moment, it's not yet clear. So we also bring our experience. Of course, this is not definitive. We have to see better data in the future. The other point is that, of course, patients with severe COVID-19 tend to die much more frequently than those with mild COVID-19. The other piece of information that we learned was that patients were dying, and in particular, those with severe COVID-19 were dying because of COVID-19. But interestingly enough, age rather than gender and comorbidities were not associated on mortality. So really suggesting that the fact of having a CLL is already enough to give you the possibility of a poor outcome. So this is what we are always suggesting our patients. There is not an increased risk of getting the infection, but when not even a higher risk to get a severe form of COVID-19. But if you get to a severe situation, then the outcome could be dismal. So having said that, now we are moving to the next phase, which is the vaccine, fortunately. So we have vaccines now, as I mentioned earlier. We are starting vaccinating the elderly next week. And then so after those, we will be starting vaccinating patients at risk, so also patients with CLL. In Europe, a number of countries already started and are quite advanced. And the ERIC is also doing a study to check the response to vaccine in patients with chronic lymphocytic leukemia. But in particular, at the moment, ERIC is recommended to vaccinate, to get the vaccine against the SARS-CoV-2 for all patients with CLL as soon as possible. And regardless the type of vaccine, we believe that any vaccine at the moment is good and is better than being without a vaccine. So having said that, we move to the topic of today's meeting. And so the guidelines for CLL treatment in first line for patients with chronic lymphocytic leukemia. And I want to take advantage of the recently published guidelines of the ESMO that have been recently endorsed by EHA. And we had a similar discussion on the web really 1 week ago. And what we wrote in these guidelines is exactly what you see here. It is summarized in this picture. So the key points are, first of all, patients who need the treatment. So of course, the usual rule apply to CLL. So patients should be watched and waited for some time, months or years, depends on the disease. And then when they develop symptoms and they have an active disease, then they need the treatment. The first stratification that you have to apply is the genetic stratification, so immunoglobulin and P53 status. So that's the first thing to be done. The fitness of the patient, the age of the patient becomes somehow collateral, is less relevant at the moment, thanks to the new drugs that are definitely better tolerated regardless the age of the patient. And then the other focus of my presentation is the fact that now we have a number of drugs that are available in first line, but in particular, the chemoimmunotherapy is really becoming, again, disappearing. So it is definitely a third or fourth choice, and there is only, as we will be discussing, probably one small subset of patients, those with mutated immunoglobulin genes, who may benefit from immunochemotherapy. But immunochemotherapy is disappearing, as also in your experience, and you know well, and the guidelines are also only reflecting what is really happening in real life, the fact that chemoimmunotherapy is disappearing. So let's focus first on P53 mutation. We know that since a long time, patient can have disrupted P53 due to the deletion on the chromosome 17p, or they can have also mutation in the gene. Patient can have a mutation on one allele and deletion on the other allele. But we have to keep in mind that there are patients who are not detected by the FISH, that is able to detect the deletion. And therefore, we have also to screen for the mutation. So we have always to remember that when we want to test our patient for the P53 status, we have always to ask and perform two different tests, the P53 mutation and the FISH. Having said that, we know that these patients with P53 aberration have definitely a much better outcome with the novel therapies. Here I show you the data with ibrutinib, the BTK inhibitor ibrutinib. This is the longest follow-up we have for patients with P53. This is the study that has been recently published by Adrian Wisner, the update at 6 years where he shows that a patient with p53 aberration, mutation, or deletion, if treated with ibrutinib first-line treatment, they have a progression-free survival, which is incredible. I would say we never saw that in the era of immunochemotherapy. At 6 years, 61% of the patients are still responding. And this is really matching very well what is happening in the general patient population with CLL, so without the p53 aberration. This is true with the novel drugs, with the BTK inhibitors in general. Here we have the ELEVATE study that compared acalabrutinib, the new BTK inhibitors, plus or minus obinutuzumab versus chlorambucil plus obinutuzumab. And again, here in this mixture of curves, you do see patient with deletion 17p treated with acala plus or minus obinutuzumab, and there is really no significant difference between all these. We have also Venetoclax plus obinutuzumab, so BCL2 inhibitors plus obinutuzumab, given only for 1 year. So fixed duration treatment, which is the difference with the BTK inhibitor. The CLL14 study, elderly patient treated with Venetoclax plus obinutuzumab or chlorambucil plus obinutuzumab. We have more than 3 years of follow-up. Here you do see patient with deletion 17p in blue treated with Venetoclax plus obinutuzumab. They have an advantage in terms of PFS compared to chlorambucil, those treated with chlorambucil plus obinutuzumab. But if you look at patients without deletion 17p or p53 mutation and treated with Venetoclax plus obinutuzumab, the outcome and the PFS is completely different. So the patient with aberrations tend to progress earlier if treated only for 1 year with Venetoclax plus obinutuzumab. This is really suggesting that in 2021, still the best therapy for the patient with p53 aberration is a continuous treatment, in particular with BTK inhibitors. Definitely everybody agrees that the use of 1 year for p53 patients is probably a little bit too risky at the moment. Now we move to the vast majority of patients, because p53 aberrations are present probably in 5 to 10% of the patients at the time of starting the first-line treatment. Mutational status can be applied to all patients, and here we have the mutational status, patient being mutated or unmutated. So we know now since a long time that the patient who benefit the most from immunochemotherapy, and here I'm showing you the data with the FCR, fludarabine, cyclophosphamide, and rituximab in young fit patient, data from the MD Anderson here on the left. The patient with mutated immunoglobulin genes in blue, they reach a plateau in terms of progression-free survival and overall survival. So suggesting that 60% of the patient, if treated with the FCR, if they have mutated immunoglobulin gene, they can have a stable and prolonged response for even more than 11 years. This has been confirmed also in the CLL8 study, comparing FCR versus FC. And again, patients with mutated immunoglobulin genes, here in green, they tend to have a plateau. Here the follow-up is much shorter, but the same thing appears to be true. Now, so for these are the patients, the only patients that can benefit probably from immunochemotherapy if they are young enough to tolerate FCR. But let's not forget that these are patients that can also benefit from the novel therapies. So there is here is the ECHO 1912 study, patient with mutated immunoglobulin genes treated with ibrutinib plus rituximab here in red, or FCR here in the black dotted line. There is no difference. So it is true that those patients can still benefit from the immunochemotherapy, but they can also benefit from the novel therapy. So it is fair to discuss with the patient the pros and cons of the two approaches. So with immunochemotherapy, of course, you can have a short treatment, but you have also possible long-term consequences like acute leukemias or MDS, and also the risk of infection persisting for a few years after a couple of years after the stop of FCR. With ibrutinib, of course, you have the disadvantage of a continuous treatment, in particular among young patients, but it's much better tolerated, and also the infections can be better managed. Of course, we don't even discuss the unmutated patients here. There is the proof that in the ECHO 1912 study, if patients are treated with ibrutinib, in this case plus rituximab, if they have unmutated immunoglobulin genes, they do much better than those who are treated with FCR, because the patient with FCR and unmutated immunoglobulin gene tend to continuously progress without reaching a plateau. Same story also for the elderly patient. Here I show you 3 different studies. The RESONATE-2 study, the original study, first line, all elderly comorbid patients, more or less a similar population, never the same. But we look at ibrutinib versus chlorambucil. These are patients with mutated immunoglobulin genes, unmutated immunoglobulin genes treated with chlorambucil. There is an advantage for the mutated patient, but nothing comparable to ibrutinib, where there is no difference between mutated and unmutated. And the difference, even with those treated with chlorambucil, is dramatic. Of course, the standard in terms of immunochemotherapy for the elderly is chlorambucil plus obinutuzumab. Here there is the ILLUMINATE study, but again, patient treated with the ibrutinib-based treatment together with obinutuzumab, here in yellow, the mutated dotted line, unmutated the straight line, they are not significant, they are not responding in a significant different manner, and in particular, they have provided benefit in terms of PFS to all patients if they are treated with chlorambucil plus obinutuzumab, mutated or unmutated patients. Same thing is true with the ELEVATE, acalabrutinib plus obinutuzumab, here in blue and purple. No differences again between mutated, unmutated, and always a benefit for all patients, mutated and unmutated, when they are treated with chlorambucil plus obinutuzumab. We are back to CLL14, the Venetoclax plus obinutuzumab study, again, elderly comorbid patient. You look at the right, patient in blue treated with Venetoclax plus obinutuzumab, mutated patient with the straight line, unmutated patient with the dotted line. They both fare better than the patient treated with chlorambucil plus obinutuzumab. Mutated genes, those with the solid line, unmutated genes, those with the dotted line. Again, if we look only at patient treated with Venetoclax plus obinutuzumab, for the mutated patient, we do see a plateau. We have, of course, we need a longer follow-up. Here is a little bit more than 36 months, 3 years, but it looks like there is a plateau. So that would be really nice, because it means that with a fixed duration of 1 year, we can replace immunochemotherapy for the mutated patient with a fixed duration. So there is no more any advantage in giving immunochemotherapy. But if you look at the unmutated patients, that are the vast majority of patients, okay, those with more aggressive disease, then again, they tend to relapse soon after stopping the fixed duration of 1 year. So again, of course, the relapse here is much slower compared to that of patients with p53 aberration. We have to see if and when the patient really needs another treatment, we can retreat them with Venetoclax again, for example. So, but these are all open questions. So at the moment, again, it's somehow tricky to explain to the patient that if they have unmutated immunoglobulins, with the fixed duration treatment, maybe they will relapse much earlier. So the future dilemma is indeed, shall we do a continuous treatment in which patient? Shall we do a fixed duration treatment in which patient? And again, the fixed duration treatment is showing a great benefit because it is able to induce undetectable MRD, so minimal residual disease, in a proportion of patients. And here you can see that those who reach undetectable MRD indeed can experience a very prolonged PFS. But those who do not reach undetectable MRD, here in black solid line, then they tend to progress much earlier, and 50% of patients relapse within 2 years from the end of treatment. So this is something, and we cannot predict at the time of start treatment who will be on the flat curve and who will end up on this curve. And in particular, Dr. Al-Sawaf presented at ASH a few months ago the fact that there are some patients who, under treatment, they have a so-called positive growth. So they are even relapsing under the treatment of venetoclax. And some instead who have a negative growth, so they tend to respond, but then the treatment is stopped. So the 1 year fixed duration is probably not correct for all patients, because someone maybe will need a continuous treatment forever. Someone will need a longer treatment for 2 years or 3 years. And this is something that is the topic of the future research that it is ongoing at the moment. So we are not aiming at anymore at the fixed duration. So one size fits all, one period of treatment equal to everyone, but we really try to terminate the therapy when it's the best moment for each and single individual patient. So this is what we presented, and actually Bill presented our study, the phase 2 CAPTIVATE study at ASH as well, where patients are treated with a combination of ibrutinib plus venetoclax. The study involves a patient in first line. There is a lead-in with ibrutinib for 3 months to debulk the patient, then 12 months of the combination between ibrutinib and venetoclax, and at the end of the 15th month, patients are screened by MRD, and those who have undetectable MRD, then they are randomized to either nothing, so a placebo, so stop treatment, or ibrutinib continuous treatment, which is probably still the gold standard. Those who do not have undetectable MRD, so they have still detectable MRD, they are not left alone. So they are not obliged to stop, but they continue something. So either ibrutinib continuous therapy or a consolidation with an extra year of ibrutinib plus venetoclax. Here are the results. 1 year disease-free survival. So the lack of progression of death in the patient. This was the endpoint of the study, is identical, very similar, or at least not significantly different from patients who stopped the treatment in placebo or continued with ibrutinib. Those who instead did not achieve undetectable MRD and continued some treatment, those who did an extra year of ibrutinib plus venetoclax were able to double the number of undetectable MRD. So vast majority became undetectable MRD, really suggesting that there is a proportion of patients who may benefit for more treatment. And of course, if you had ibrutinib, there were no undetectable MRD, because ibrutinib, we know, is not able to induce undetectable MRD. But these patients, all these patients, did not progress. So those with confirmed undetectable MRD treated with placebo or ibrutinib. Those without undetectable MRD treated with ibrutinib or ibrutinib plus venetoclax, they all had a 30-month PFS, more than 95% of the cases. So really suggesting that if you really apply the best treatment to each patient, depending on the quality of the response and depending very likely on the biology of their disease, then you probably get an equal long-term control of the disease. So having said that, I'm happy to start the discussion and reminding you that indeed we are not going anymore for a one-size-fits-all type of therapy, but we are really aiming to tailor and individualize the therapy for each of our patients. Thank you very much for your attention. I'm open to any question that you want to place.
Thank you, Dr. Ghia. I would like to ask the participants if they have any question to post it in the Q&A session. Just a question now, based on the Alliance trial, I mean, the addition of anti-CD20, in particular rituximab, has not added any benefit to ibrutinib, while in the ECOG 1912, the regimen that is used is ibrutinib plus rituximab. Now, if you want to treat somebody with a continuous therapy ibrutinib, would you add rituximab or not?
No, definitely. Besides the fact that in Europe it's not approved, and I don't know if it will ever be. Indeed, there is no benefit, as you well said. There was also a previous study by Jan Burger and Andy Anderson showing exactly the same thing. So now we have more than one proof that the addition of rituximab to ibrutinib is not worth it. Probably not even obinutuzumab, because from the Illuminate study, the PFS curve is very similar to what we saw in the Resonate 2 study with ibrutinib alone. It is true that we cannot compare studies, but you don't get really a feeling that something extraordinary is happening. This is probably also explainable because ibrutinib is somehow affecting and modify the ADCC response, so the response, the cellular response to antibodies, so it's decreasing the efficacy of antibodies. There might be a lot of explanation. What is interesting at the moment is, for example, that with acalabrutinib, we have studied, and we show it, the Elevate study, where there is the patient are treated with acala or acala plus obinutuzumab, and it seems that they are different a little bit. The study is not powered to show any difference, but we will see with a longer follow-up, maybe with other BTK inhibitors, that might be an improvement with anti-CD20 antibody. But in CLL, this is not really, with ibrutinib, is not really adding much.
All right, it seems that we have a question here. In 2021, do you think there is any role for BR, bendamustine rituximab, in CLL, or it should be out of the map?
This is a very nice question, because even in the era of immunochemotherapy, I never liked so much BR. I think it was a good therapy for the relapsed refractory setting, 70 milligrams in patients who already received another line of immunochemotherapy. So you were already aware of how the patient was somehow responding or not, also in terms of adverse events. In first line, I have to admit, I never been able to use it, meaning that if you use the full dose, 90 milligrams, for 6 cycles, it's really tough. I mean, for the patient, it's really tough as a treatment. So we were always wondering, if I believe that the patient will tolerate the adverse events of bendamustine, then very likely he will be able to tolerate FCR. If I'm a little bit concerned about FCR and adverse events of chemotherapy, I'm not confident of using bendamustine, so I would have moved to chlorambucil-based treatment. So it was really difficult for me to find the exact window of opportunity for bendamustine. Then, of course, when you look at the papers and you talk also to colleagues who are using bendamustine, and I would like to hear the opinion also from the colleague who asked a question, if you use it at reduced dose, 70 milligrams, also in first line, if you use it for 4 cycles instead of 6, then of course it's better tolerated. But you are not delivering that PFS, expectation of PFS, that is what you would like to see with bendamustine, which is probably roughly almost 3 years of median follow-up, of 3 years of PFS. So this has been always my concern. So nowadays I'm lucky, because with the novel therapies, I don't have to think about it anymore.
Well, I agree with you, but there are still probably some patients. I mean, you know, the classification of frailty in CLL is quite confusing sometimes. And the no-go, the slow-go, or the go-go, I mean, you know, all of these classifications. And we know from the CLL-10 trial that especially those above the age of 65, I mean, who benefited more from BR as compared to younger patients.
You are very correct. But if you look at the table on the CLL-10, if you look at the table of the adverse events, you do see that there are less infections, less cytopenias in BR compared to FCR. But still, 1/3 of the patient will get a cytopenia. One third of the patient will get severe grade 3 or more infections. It is true that with FCR, you get 50% or 56%, fine. But when you start the therapy, 1 out of 3 patients will have a grade 3 or 4 infection, which I don't like so much, in particular because they are elderly, as you are saying, so you treat people above 65 years of age. So their capacity of coping with an infection is different. So I have to say that I'm happy when in Italy, for example, we have access for the elderly above 65 years of age to novel therapies. So I'm always happy to go for those.
Now, in the recent ESMO guidelines, they have still kept FCR as an option, even for the unmutated group. Now, which patients would you really choose FCR?
There is a star. There is a star there. And the star, I have to say that I am responsible in part of that star because it's written based on the access to drugs. Because in Italy, as I mentioned, I alluded now, only patients above 65 years of age have access to ibrutinib, and ibrutinib is reimbursed. If you are below 65, the only option you have is immunochemotherapy. That's it. So,
but if you are in an ideal world where you have an access to all drugs at all time, which patients you would choose FCR and which patients you would choose ibrutinib in the unmutated group?
Nobody. Unmutated, nobody.
So you will not choose, I mean, you will not give anybody FCR, you will give everybody ibrutinib.
Yes, absolutely nobody.
Despite being indefinite treatment with...
Yeah, but the issue is the following. Unmutated patients tend to be more genetically unstable. So if you give immunochemotherapy, you are probably pushing even more instability, increasing the rate of gene mutations and therefore a worsening of the disease. So when the disease relapse, and it will relapse in every patient, as we saw the curves, it will be a much different disease, probably more difficult to be treated. So that's the idea that we have in mind. So we consider the unmutated patient as a biologically aggressive entity. So we want to go soft with it, let's say, with the biological approach rather than with immunochemotherapy, because we know that we are not controlling it. We are just postponing a much more aggressive disease. So for unmutated, if I am free to do it, and indeed I have to say that in the past few years, I never treated anyone with FCR because I'm lucky enough to have a clinical trial. So whenever we saw a patient with unmutated genes, we were always advising the patient to enter a clinical study.
So how about the mutated then? I mean, you know from the ECOG 1912, and you have shown these curves, still ibrutinib-rituximab did as well as FCR. But we have long-term data for the FCR where we have a plateau around 60% or so for patients who have been treated more than 10 years ago. Which patients, again, the same question,
so,
would you choose ibrutinib?
For the mutated patient, we do discuss, as I mentioned earlier, we discuss openly the two options. So we don't say, as now some hematologists tend to do, the best treatment for you is FCR. It is not true. I always say you are lucky enough that you can choose, okay? But there is not a best or worse, because every treatment has his disadvantages and advantages. I'm always concerned more, so the advantage of FCR is the short duration, but I'm always concerned about the clonal evolution under immunochemotherapy. And in particular, I'm always concerned on the fact that 60% of the patients reach a plateau. The other 40% do not reach the plateau. So if we exclude patients with deletion 17p or deletion 11q, it's 75% who reach a plateau. So it's 3 out of 4. But I always say to my patient, look, it's not that you are sure to get on that plateau. It's 3 out of 4. So I always discuss very openly, and I tend not to be biased. I think that now with longer follow-up, also with ibrutinib and with all the other drugs, we are accumulating data and seeing that indeed the median PFS for patients under ibrutinib is really is not yet reached after 7 years. So we will be showing the data also, new update at ASCO in a few months. So we really don't know, especially for mutated patients, the prediction is very positive. But it's true that it's an open question. The only thing that I would advise everyone, before calling mutated a patient, be sure that the laboratory that is giving you the results is ERIC certified. So be sure that the analysis is reliable, because when a mistake is done, is always in the sense of calling mutated a patient who is unmutated. The opposite never happens. So the risk is to call mutated someone instead who would benefit from the immunochemotherapy. And second point, you have to exclude the patient with stereotype receptor, the subset 2, the famous subset 2, IGHV, because those are not responding to the immunochemotherapy. Still, they are called as mutated, so they should be sorted out and treated with something else.
Just one last question before the case. I guess you have a case to be presented.
Yes.
Now, we have accumulating data about fixed duration therapy. It's just that probably we don't know for how long. Especially the CAPTIVATE that you have shown in your last slides seems to be very promising. What do you think in the near future would be fixed duration or indefinite? And would you use more of fixed duration rather than indefinite therapy?
So the issue of the future is that in the near future, probably in the midterm future, I'm afraid that all the approvals will be with fixed duration, because it's easier for everyone, for the health providers to reimburse the drug. It's easy, 1 year, 2 years, I know upfront how much I'm going to pay you, that's it. So that's still my concern, because as all the studies with fixed duration are showing, is that there is always a portion of patients, which is even large, so it could be 30% of the patients in the CLL14, they are not well served with that fixed duration. Might be 1 extra year, might be 2 extra year. So I think that one should really, and I hope now the studies will provide data, and we have an ongoing study, for example, at my institution, where we start with Venetoclax. Whoever gets into undetectable MRD, we stop. Those who do not achieve undetectable MRD, we do Venetoclax plus ibrutinib. If they get to undetectable MRD, they stop the treatment. And those who do not reach undetectable MRD, even with a combination, they continue ibrutinib. So we really select the best treatment for everyone. The CAPTIVATE study goes into that direction. So I hope that will help, but it's a phase 2. So but it will have, maybe will help for the approval of this sequential strategy, which I think it will be the best for the patient. So we should really check in every single patient what is the level of response that we achieved before telling them, look, it's 1 year and that's it.
All right, thank you.
I know I didn't answer, but it will be a difficult decision. It's really a difficult decision.
It's very hard to predict.
Because the continuous treatment, we know that it's good for everyone, but of course we also know that it's not it's costly. It has adverse events, so it's not the solution. Also there, fixed duration is not good for everyone. So we have still to find the right way to go.
All right, thank you very much. I mean, there is a question about toxicity, but probably
I saw that. We answer after the case.
Probably after the case.
Yes.
Right. So we'll go ahead with the case. Thank you.
Yes, indeed. So here is, before starting the case is indeed based on toxicity, because I think this is the issue. Now, I don't think that I need to show you. You are all well aware of the fact that the new drugs are better than chemotherapy, are very effective. The life expectancy of our patient improved enormously. So I don't have to show you that. I don't have to convince that. I think that the issue nowadays in 2021 is really the management of this new therapy, the management of the toxicity and the adverse events, so that we don't stop the patient, the treatment in the patient, because then we will fail them and they will not benefit of those very nice results in the long term, because if the patient doesn't take the drug, of course, it will not respond for a long time. So here, that's the issue, because all the different drugs, though they are better tolerated than immunochemotherapy, they all have adverse events that we should be aware of, and we should also learn how to manage and control. And I want also to underscore, because I always like to remind you that infection remains an issue even with the novel therapy. They are more manageable, they are less severe compared to immunochemotherapy, in particular because if you stop any of these drugs after 2 or 3 days, the immune system is back to where it was. It's not like with immunochemotherapy where the immunodeficiency remains for a long time, but still is something that we have to keep in mind. The other point I want to make, and this came from the CLL-12 study, where patients with CLL without need of treatment, so this was a preemptive therapy, they were either treated with nothing, so watch and wait, or ibrutinib, to see if that could prevent the progression of the disease. But beside the results that at the moment are not definitive, are not really giving a clear answer, the important thing is that if you look at here, 95% of the patients under placebo experienced adverse events, exactly as those under ibrutinib. So this is just to remind us that patients may have problems because they have other comorbidities, because they are elderly, because for many reasons. So it's not that when they complain about something, we have always to refer the concern or the complaint to the drug, okay? Of course, under the drug, there are certain events like arrhythmias, and we are entering the issue of atrial fibrillation or bleeding, which are much more frequent among ibrutinib. But if you look at diarrhea, if you look at neoplasias, if you look at infections, they are all the same. Maybe there is a protective effect against the myocardial infarction due to the ibrutinib effect on platelets, but this is not clear. But just to tell you again that not everything that happens to a patient under ibrutinib or under any of the novel drugs has to be referred always to the drug itself. So we know with ibrutinib and BTK inhibitors in general that we might expect a number of events, adverse events, that they tend to disappear with time. So if you look at green, the first year of treatment, or red, the fifth year of treatment, you do see that they all decrease, with the notable exception of hypertension, which tend to accumulate with time. But you know, hypertension can happen anyhow because these are elderly patients. We know how to control it, so it's not a major issue in the clinical practice. The adverse events of clinical interest, indeed, as you well know, is bleeding, hemorrhage, in particular the major hemorrhage, atrial fibrillation, as mentioned by the colleague here in the question and answer section, and as mentioned also hypertension. So regarding the bleeding, maybe 1/3 of the patient, maybe 50% of the patient can experience bleeding. It's very frequently low grade, mild, and nobody is concerned about that. We always inform the patient in advance to prevent any concern. We always say that it's not gonna, what they see is what they get. This is the typical sentence that we say, so it's not going to worsen with time. The first manifestation will remain exactly the one they will have for some time, and then it will disappear. So that's the other important message for the patient, that the bleeding will disappear. The issue, of course, is major hemorrhage, which may occur in 4.1% of patients, of course, throughout at least 3 years of follow-up. In only 1% of the cases, the patient will discontinue. So the frequency is very, very low. The other point, as mentioned, is atrial fibrillation. Again, we have to keep in mind that we have a value which is 5%, maybe 10% in some series. It is mostly occurring during the first 6 months of therapy. Okay, and typically the patients are are prone to have atrial fibrillation, so maybe they had already an atrial fibrillation event, or maybe they are simply elderly, male with hypertension, which is the typical profile of a patient who is at risk of developing atrial fibrillation. As you can see, then it tends to disappear. Again, atrial fibrillation, one has to deal with it as the cardiology suggests, so we don't have to say anything. There is nothing different with the atrial fibrillation that occurred under ibrutinib compared to the one that occurs spontaneously. So here I show you a case which has been actually the first patient in my life that I treated with ibrutinib first line. So after many years of experience with patients in the relapsed refractory setting, but it's true that when we started using first line, some things came out much more prominently. So this was an 8 years old man with the CLL and autoimmune hemolytic anemia. As per guidelines, we tried to give corticosteroid, high dose corticosteroids to control the autoimmune anemia. He responded, but when we scaled down the corticosteroids, then he relapsed. So we had to keep him under steroid, which is not good in a patient with CLL, in particular an elderly patient, for the risk of infection. So then we decided to start an anti-leukemic treatment. There was the Resonate 2 study open, so we enrolled the patient, and we then, as you will see, it has been randomized to ibrutinib. This was the comorbidities. He has COPD, hypertension, some arrhythmia, not really atrial fibrillation. Strange story. He was getting some antiarrhythmic drugs, prostate hypertrophy, and of course the autoimmune hemolytic anemia. So I would say a picture that is quite typical of an elderly patient with CLL or an elderly patient stop. So what is the first line treatment you are going to propose? There should be a poll coming up. So here is no treatment indication. In this case, I just cut in short the study.
Get the poll, please.
The case, and so I don't show you the reason of starting treatment, but we may discuss if you want to keep and proceed with wait and watch and keep the patient on corticosteroids, or would you use a chlorambucil plus obinutuzumab because indeed of the hemolytic anemia, bendamustine plus rituximab, which I heard it's a favorite here, or ibrutinib, which at that time was a novel therapy. I don't see the poll.
The poll, please.
Coming up.
It should be.
Any moment. Hey,
Yes,
here we go. So, what would you do? There is someone who would like to keep it anyhow and wait and watch. Chlorambucil plus obinutuzumab, bendamustine plus obinutuzumab, ibrutinib. So
it seems that we cannot vote ourselves.
We cannot vote. I hope we can see the results.
Yeah, the attendees can vote. Maybe in a few seconds we will see the results. So
we leave you 10 seconds. It's quite straightforward. And we will get the answer. Multiple choice, but vote only one. Don't vote too many. So maybe we can stop here and see the results.
Can we see the results, please?
Here we go. Okay, very good. So still I would say the vast majority will go for immunochemotherapy, and as expected, there is a tight match between chlorambucil plus obinutuzumab, bendamustine plus rituximab. I might understand that because for autoimmune hemolytic anemia, in particular at that time, there was no much experience. Now we know that ibrutinib is controlling hemolytic anemia, is not inducing hemolytic anemia, so it can be used even in patients with an uncontrolled hemolytic anemia. So always remember, hemolytic anemia per se is not a criteria to start anti-CLL treatment. One should use high-dose corticosteroids, but if the patient is resistant to corticosteroids, then one should use a therapy. I understand that one might prefer a chemotherapy-based treatment. We are using, in the past, we were using a scheme that was proposed in Italy, cyclophosphamide plus corticosteroids and anti-CD20. But I mean, I understand that there is still many of you who voted for immunochemotherapy. Anyhow, we can close and move on. As I said, we used ibrutinib at that time, enrolled in RESONATE 2. Everything was perfect. After 4 months of treatment, 3 months of treatment, the patient came to us and had this atrial flutter. So not really fibrillation, only atrial flutter, as the cardiologists like to distinguish. So this is another question. How would you manage this patient? Now the patient is taking ibrutinib, it's only 3 months, so the disease is not yet well controlled. Would you forever permanently discontinue ibrutinib because it's too dangerous? You would stop ibrutinib and start after resolution of the atrial fibrillation, but at a lower dose.
Second, please. Yes, go ahead.
You would not do any changes in concomitant medication because he was already actually taking an antiplatelet drug, or you would continue ibrutinib and evaluate the indication for anticoagulant treatment and see if to change the treatment or not, and consult with the cardiologist. Please, let's vote. Now the poll is coming up. We are running a little bit late, and now here's the question again. Permanently discontinue ibrutinib forever, stop ibrutinib and restart, but at lower dose, no change, nothing. He's anyhow already on anticoagulation, or continue anyhow with ibrutinib, but evaluate an indication for anticoagulant treatment. So let's see the results. And yes, indeed. That's the last, the winner, let's say, is exactly what we did, but I understand the stop ibrutinib. There has been a period in which we were all suggesting to stop ibrutinib, send the patient to the cardiologist, try to put the patient back to rhythm, and then restart the therapy. We never suggested to start a lower dose, because it doesn't seem that there is really a dose effect on the atrial fibrillation. There are some patients who are prone to develop it, some patients who are not. But the stop and go was indeed suggested, and I was doing also on my patient in the past. Now we learned that this is not necessary. There is no risk of keeping the patient on ibrutinib, even if they develop atrial fibrillation. And in particular, our cardiologist, who now like to be called cardio-oncologist, they really want they want to see and visit the patient under ibrutinib, because they want really to put the patient back to rhythm and decide the anticoagulation with the patient under ibrutinib, so that they have everything under control and they can really dose the drugs with ibrutinib around. So that's exactly what we do. So we continue ibrutinib, we send immediately a patient to the cardiologist, and then he decides what to do. In this case, the patient did some acute management. Then in the long term, he was able to undergo a catheter ablation. But still, being a patient who developed atrial fibrillation, he is at risk of developing again, should he get oral anticoagulation or not. So as you know, you go, there is, one has to estimate the risk of stroke, and so see if the patient needs anticoagulation. Everywhere around the world, I understand the cardiologists follow the same CHA2DS2-VASc score. And I have to say, unfortunately, our patients always fall into those who need anticoagulation because they are old, they are male, and they have typically hypertension. So that they have for sure many, they gather, collect many points. So in most cases, they need anticoagulation, but it's good always to make it, to have an evaluation to see and identify those few who don't need. So the other point So this is the scheme. The other point is, of course, if there is an increased risk of bleeding in our patient, and again, many times there is an increased risk of bleeding, again for the same reason, because the risk factor for bleeding are more or less the same for stroke. So it's difficult to dissect and define the risk of bleeding, in particular because this algorithm has been modified after ibrutinib, and now it includes also ibrutinib as a risk factor for bleeding. So at the end, we may always think that the patient has some increased risk of bleeding when associated with anticoagulation because of the anticoagulation. So we have to know that the anticoagulation gives a risk of bleeding, but that is true in every patient with atrial fibrillation, but we have to consider the fact that they have also a risk of stroke. So we just keep this question because we are a little bit late, and we go directly to the choice of anticoagulant. Nowadays, nobody is really using warfarin with ibrutinib because it's not contraindicated, but there is no data in clinical trials of the concomitant use of ibrutinib and warfarin. We are using novel anticoagulants that are much safer in general. We were using the dabigatran in the past because it is not interacting with the CYP3A4. So, and it is mainly excreted through the kidney. But I have to say that now the consensus is to use apixaban because it's much easier to dose, so you can reduce by 50% to 2.5 milligram instead of the 5 milligram. Instead, with dabigatran, you can only decrease from 150 to 110, so you decrease only 30%. And apixaban has been shown to give less bleeding events among the elderly. We don't know anything in patients with CLL, but since they are mostly elderly, probably this is a good choice. But any of these novel anticoagulants and also the new that are coming are good enough. So this is what I want to conclude. As mentioned earlier, personalized treatment. At the beginning, it's personalized based on the efficacy, but we have also to personalize the treatment based on the tolerability and the adverse events. So maybe we have really to distinguish the type of treatment that we have to give to patients based on the comorbidities that the patient may have and may experience. Thank you very much for your attention. These are all the people working with me in Milano and around the world. And here again, time for discussion of, maybe we are over time, but a couple of questions.
Yeah. Yes, thank you very much, Dr. Gea, for this case and the recommendations, and mostly talking around the toxicities that we expect from ibrutinib and BTK inhibitors and how to deal with them. I guess a question here, you've seen it.
Yeah, if you want, I can, yes.
Yeah. You have answered this question about using anticoagulation, and then it seems that there is no problem.
So the cardiac stent, I want to add something. This is a very appropriate question because usually after a cardiac stent, they give always two anticoagulant, or at least an anti-aggregant, antiplatelet plus an anticoagulant. So this is definitely contraindicated. So whenever you have two anticoagulants or two antiplatelets drugs, don't use ibrutinib. But keep in mind that again, this is usually for only 6 months, and then the patient will be put only on one anticoagulant. So we did that. We waited a little bit, like for the COVID-19. You know, you can wait few months in order to discontinue at least one of the two anti-aggregants or anticoagulants. It happened to me once that the patient, we decided to start ibrutinib. He went home, and then he had a myocardial infarction the night. Maybe he was worried, and so he underwent a positioning of the stent right at the beginning of our therapy. So we didn't start it, and we couldn't wait 6 months. So we started another therapy. So that's the only situation. Otherwise, all the other cases, we always waited 2 or 3 months in order to start ibrutinib. For the cardiac problem, it's difficult to define cardiovascular problem, you know? So having had an atrial fibrillation episode in the past is not a contraindication to start ibrutinib. Having an actual, an ongoing atrial fibrillation is not a contraindication to start ibrutinib. Actually, what my cardiologist always says, the patient has already atrial fibrillation, nothing worse can happen. So you already know it's all very well controlled, is already aware about the use of anticoagulation, so perfect patient to start with. In other problems, it's difficult to evaluate because there is actually no association between myocardial infarction, if not even a protective effect, as I showed you in CLL12, and ibrutinib. So, of course, if a patient has a heart failure, an ongoing heart failure, you would not start any therapy at all. First, you want to control well the cardiac failure. And a patient who is in an uncontrolled heart failure chronically, then you cannot even start Venetoclax because you have to hydrate the patient, so you have even a higher risk of heart failure. So I think these are complex patients where maybe the treatment for CLL is the last of their concern and they have major issues to control with. But all the other patients, I mean, can be easily managed. Additional rituximab to ibrutinib, we said earlier, there is no advantage, so there is no reason. In the US, they use it in some patients, like young patients, to have a drastic reduction of the lymphocyte in the peripheral blood for cosmetic reason, not for other reasons. Maybe in the future it will be the way to stop ibrutinib, but at the moment we are not allowed to do that. We don't have any results.
All right, I guess we are at least 7 minutes past our time.
Sorry for that.
No problems. I mean, I guess at the end of this, we have to conclude. Well, thank you very much, Dr. Gaya, for your elegant presentation, very elaborative, and I mean, your notes from your experience about how to tackle the toxicities from BTK inhibitors. And I would like to also thank Janssen for sponsoring this meeting today. And thank you very much. And this is our next webinar, which is going to be next Saturday, about what is the latest in multiple myeloma, a focus on monoclonal antibody. Thank you very much, everybody, and have a good night.
Thank you.
Thank you.